we've discussed the aspects of normal immune function and how sometimes, despite the intricate control mechanisms, the immune system can become disordered and turn upon self-structures, hence the term autoimmune, self-immune. The question comes, why do we use tests, and what tests do we use when we're considering autoimmunity for someone with unexplained fatigue, unexplained inflammatory joint pain or rash? Well, first I should point out, primarily as a clinician, that 90% of our diagnosis is based on the story, which is why even in the era of telehealth conferencing, which we're facing in COVID at the moment, we can make a good go at diagnosing a patient's problems even without seeing them. Of course, that's not always the case, but it's helpful. And there's only about 10% left that will rely upon a good examination of the affected area and the use of judicious diagnostic testing, which often involves blood tests but can involve things like biopsies, etc. And there are three main purposes for doing these tests. One is to try and confirm, or at least help to establish, what your suspected diagnosis is, so your diagnostic purpose. And then there's a monitoring purpose. So once you've diagnosed someone, say with lupus, following them and seeing if they are actually under control or whether there's some grumbling activity going on, even below the level of their awareness. And of course, we need to remember that there's a need for regular surveillance of the health status and screening. One additional thing I would add there is that some blood tests have prognostic value. Pro means before, gnosis, knowing. So knowing beforehand what's going to happen. For example, we know that people who have a SCL70 antibody are more likely to later get problems with autoimmune muscle damage, causing muscular weakness. Similarly, people with an SSA antibody are more likely to get rash and mucosal dryness. The diagnostics, we should really think, even if only fleetingly, about autoimmunity in any individual who presents with fatigue. And I know that 90% of those people, it'll be because they're commuting to Sydney and they've got 4 kids and they're doing their masters and they're climbing the executive ladder, or they're just a mother, how dare I? A mother who is looking after a big household. But fatigue is a good screening question. After that, asking about things like symptoms of joint pain, rash, etc. And how do we establish a problem? We would normally look at the sorts of things that might cause fatigue, which often give us a clue to other autoimmune problems. So what makes you tired? Well, often you're nutritionally deficient, so we need to know what your B12, your iron, your folate are. You might be anemic, you might have heavy periods, losing iron, that could make you feel tired. You may indeed be underactive with your thyroid. We mentioned that thyroid problems affect about 1 in 20 people. There may be something going on with your liver or your kidneys, which can present with fatigue. Another marvellous thing about the body is that you've got to knock out 90% of that structure before it actually starts to manifest clinically. So in other words, if you were relying simply on symptoms to diagnose kidney failure, you'd have to wait till 90% of the kidney's gone before you would eventually get symptoms. So there's certain role for doing regular preventative biochemical and other tests. If, for example, we were thinking about rheumatoid, remember that 10% of those patients are negative for their rheumatoid factor, and similarly about 1 in 10 celiac patients will be negative for their blood tests. So while pathology is important, it is not the be-all and end-all. And I would also argue that just because you've got an anti-nuclear antibody does not mean that you are destined to develop an autoimmune condition. But let's talk a little bit about autoantibodies. So anti-nuclear antibodies, as I said, originate from damage to the skin often, or other parts of the body where there is a release of structures from the nucleus to which the body then makes antibodies. And then the antibodies and the parts of damaged cellular structures combine to form what we call immune complexes, which sediment out into the small vessels or organs like grains of sand, creating an inflammatory response. When we ask for an anti-nuclear antibody or ANA, if we're suspecting lupus or scleroderma or Sjogren's or anything in that family, a blood collection will be taken by your friendly venipuncturist, and it'll be couriered along to the lab, and it'll be diluted 1 in 40, and then 1 in 80, then 1 in 160, and then it'll be dropped onto a glass slide where if we then put another drop on there that glows in the dark, and if it's positive, that person has an ANA, an anti-nuclear antibody. And there are different patterns which are quite striking that can give clues to the type of autoimmunity that we're dealing with. For example, you might have a homogeneous pattern, which is where there's staining of both dividing and resting cells, and that's very characteristic of lupus. You may have a certain type of speckled pattern, which is very characteristic of Sjogren's. There may be staining of the tiny little structures within the nucleus called nucleoli, and that is starting to make you think of scleroderma. And finally, there's a star-like appearance which is seen in limited forms of scleroderma. The thing that we need to keep in mind, though, is that just because you have an anti-nuclear antibody does not mean you have a disease. A lot of the patients I speak to have been referred because they've been fatigued, they've had an ANA done and it's turned out to be positive, or because their mum and their grandmum had some sort of immune problem and they wanted to be screened for their condition. Having an ANA alone is not a diagnosis. 1 in 5 healthy people have ANAs, and it may be even more than that if we look at older individuals. So you've got to have the symptoms as well. But once the diagnosis is established, then we can use pathology tests as a way of monitoring. So let's assume we've made our diagnosis, we've found a pattern that suggests that there's a particular type of autoimmune disease. We've looked at the inflammatory markers and we've found that there is some activation in the body. We've checked to see if there's any kidney damage or liver damage. We've checked the lungs to see if there's any abnormality there, or the heart to see if it's pumping correctly. And all of these things represent part of the ongoing monitoring of the patient with lupus, because sometimes just relying upon how someone feels, as we said before, is not quite enough. The critical things to monitor, well, first, don't pay too much attention to your ANA. A common scenario will be a patient will come and say hello to me, and their first question, my first question will be, how are you going? And their first question will be, what did my blood show? And I say, no, let's get it the other way around, because the bloods can be misleading. In fact, ANA, once it's there, it will always be there for life, whether you're well, whether you're sick. And so some people say don't repeat the ANA once you've got the diagnosis. Others say repeat it periodically to see if there's a change in pattern, because there can be transformation or overlap of one autoimmune condition to another. But please don't focus too much on the number. Some people say, what's my number today? Is it 640 or 1280? Well, that might well depend upon whether the technician reading it at the end of the scope has myopia or not. So we do not base our decisions on that. Complements are very important, though, because complements actually form part of the immune complex. And so when there's active disease, they get deposited out and complements go down. In some people, double-stranded DNA antibodies will be a good marker of activity, and often inflammatory markers will be useful too. So things like C-reactive protein, CRP, or the ESR. However, there are many people who are quite demoralised when they're told, they come in, they say, I feel awful, your drug's not working. There must be something wrong with my bloods, and I work my way through each result and it's all normal. And I say, that's all right. That just means that you may well have a flare, but it's below the limit of detection of current technologies. So please do not overemphasize the role of those tests. We regularly check for side effects of various medications. Steroids are commonly used. They can cause problems with sugar elevation, cholesterol elevation. We would need to look for signs of liver function changes with things like Imuran or with methotrexate to a lesser extent. And also we need to remember that unlike most things in medicine where we're taught to find the most efficient way of diagnosing a problem, in other words, don't make two diagnoses when you can make one. In autoimmunity, you throw that rule out the window, and if you find one autoimmune disease, you may well later find another one. These things occur in clusters. For example, thyroid disease will often later be accompanied by B12 deficiency due to an autoimmune attack on the lining cells of the stomach, and also urticaria, hives, which when chronic is autoimmune in about half of cases. So checking periodically for things like thyroid, celiac if the story points towards it, clotting tendencies due to antibodies to normal clotting factors, and nutritional deficiencies are all very important. And also we need to check for the side effects of the medications. At a more broad level, I should mention, and it is a shocking and somewhat pessimistic piece of news, but the rate of heart attack in women, young women with lupus, for example, is 50 times the general population. And so we're not just talking about controlling the lupus, we're talking about controlling one's life, and that means very vigorous attention to vascular risk management, which means don't smoke, control your blood pressure, keep your cholesterol in an acceptable range, don't get your sugars up, get regular exercise, manage your stress in whatever way you can. Sometimes you can't avoid it, but you can maybe change your response to it. Regular visits to your primary carer are essential. There is sometimes a tendency to dismiss the role of the primary carer and go straight to the specialist. That's probably not a good policy, I would argue, because the specialist will be looking at their part of the body, but they won't be looking at the holistic approach necessarily that's needed. And things like bone density checks for people on steroids are very important as well. Monitoring weight, checking the eyes to see if there's any plaquenal side effects, performing appropriate cardiac investigations if needed. All of these are very, very important. And so it is very important that it sounds very dry, almost legal, but we need a contractual approach where you and your medical carer together agree to a plan where you will take your tablets, and this is not in a patriarchal way, but you'll take the tablets because that's the only way they'll work. You'll acknowledge if you've got any concerns, and you'll make regular contact to live well with your illness and not, at the same time, not let the illness take your life over, but emphasise quality of life and emphasise control of lifestyle factors as we've discussed.